This is the surgical video of a patient who had shrapnel injury to the upper trunk of the brachial plexus. The entry point of the shrapnel can be seen on the right side of the neck. On doing Tinel's here, the patient had severe pain going to the arm. Patient had abduction of the shoulders to 15 degrees, had no elbow flexion, had external rotation, and hand functions were fine. Incision was marked on the posterior border of the sternocleidomastoid and 2 fingers above the clavicle. After incision, skin and subcutaneous tissue flap was raised in a superior lateral direction. After raising the flap, we felt the shrapnel. The shrapnel was dissected out and removed. We then located the posterior border of the sternocleidomastoid and excised part of it. View from above, this is the sternocleidomastoid, below this the internal jugular vein, and we will be going to this lateral fat pad to take out the plexus. View from just above, this is the sternocleidomastoid, then the internal jugular vein, then the fat pad that we have taken out, and this is the omohyoid muscle. We now dissect out the phrenic nerve and the anterior scalene muscle. There is quite a bit of scar in the area, so we proceed very carefully. We find a nerve in the area, and this may be the phrenic nerve. We test it. We now look for our C5 and C6 of the brachial plexus, and here we find a C5 and C6 coming together. We now find the suprascapular nerve and test it. It's working fine. We find the point where the shrapnel penetrated the C5 and C6 trunk, causing a partial injury in the C5 and C6 trunk. We free the plexus proximally and distally, place a flat forceps below the injured area and start cutting the nerve by bread loafing. In this technique, we cut nerves just the way we will cut a bread loaf till we reach good margins which are not scarred and are bleeding. To bridge the gap, we take a nerve graft from one of the superficial nerves of the arm. We then proceed to do a single Oberlin transfer from the ulnar nerve branch. We are doing this transfer to augment our nerve graft repair, since Oberlin transfer has very good outcome. Checking to make sure we have a motor nerve fascicle for our transfer from the ulnar nerve, and checking the biceps branches which are not functioning. There's no movement coming. We took 2 small fascicles from the ulnar nerve and anastomosis can be seen. Results at 9 months and at 1 year's time.